So if there's a relationship with autism, ADHD, and atopic dermatitis, is there a relationship with atopic dermatitis and stress? And then does that tee us up to there's some immune response that could be related, or am I overstating that?
Well, we're going back to the T cells. You're talking about the inflammatory hypersensitivity, inflammatory system that's already hyped up for atopic dermatitis. And going with all those other diseases that all respond to inflammatory reactions. They're all external stimuli. So you're stimulating this in the secondary inflammatory system. So yes, with one goes with the other. How's the diet? Stress always makes everything worse because then we have dopamine receptors going on serotonin. Yeah, exactly. Everything is all sparking off. So when you do this, what T cells are associated with it? The inflammatory ones that are mast cells. And when you start to get inflammatory mast cells, histamine just releases. And what happens? You start to scratch. But also the other histamine receptors in your stomach, right? H2. So now you have the acidic acid indigestion, GERD, all that, which would go with celiac disease and all those other diseases as well. So yes, hypersensitivity of the sound, touch, stressors all would make atopic derm just flare out and be associated with all those other conditions that do the same thing. And there's definitely more study that needs to be done. It needs to be looked into these links because they can't communicate as well. So how do you treat them as well? And then, people think, oh, you're fine. They're not fine. Lack of communication, especially for like autistic children who are very smart. So it's just that lack of socialization and communication they can't give you.
Yeah. And so then the next issue might be, have you found that when their autism is underneath better control or ADHD is underneath better control, do you find that the atopic dermatitis gets better, or is that an overreach?
I think we need to study that more, but I would think that it would.
Yeah.
I would think that all are part of this inflammatory cascade. If you can fix one, can you fix the other? Yeah, so I would go further into that, and I think more research needs to be done with it.
So this leads us right into these special populations. How do you approach patients who are, let's say, pregnant with atopic dermatitis or infants who have atopic dermatitis?
So pregnancy, you got to be careful with everything that you approach with because you don't want to damage the unborn child, or in a sense, at that same time, damaging the mother as well. So you're going to do less. It depends on you have to be in communication with the obstetrician, make sure that they're okay with topical corticosteroids because you can be, even though they're category C, and you want to just know, is it more harmful not to treat her than to treat her? So definitely, but antihistamines are safe enough to use and topical emollients and taking away things. But the calcineurin inhibitors like Elidel and Protopic you can use. So you can use those as well. They're non-corticosteroid cream, and you can use.
And that's for infants as well?
Infants as well. And I treat infants with corticosteroids. I have no problem with that. You do them for a shorter period of time, but you definitely want them to stop scratching. And they're the oral versions of the antihistamines as well.
Okay. And what about the elderly? How do you approach them?
They can get any medication they want as long as they ain't got the comorbidities that inhibit them from getting it. They can get Dupixent. They can get all that. It's 12 and above. I'm sorry, Dupixent is 6 years old and above. So you can go down into 6-year-olds and up and above. I mean, if someone is elderly, not every elderly person has a bunch of comorbidities.
Yeah.
So you can treat them with Dupixent, you can treat them with Rinvoq, Cibulco if they're very severe, but they're good at topical corticosteroids. And then you have to think about homeopathic ways of treating people. Like Flexidor is really great with anti-inflammation if you can tolerate the taste, but it works really well.
What is it again?
Flexidor. Flaxseed oil.
Oh, okay.
Flaxseed oil is excellent. You can use it for psoriasis or eczema.
Put it in your food or?
Yes, you got to be able to swallow that. As long as you can swallow it, it's good. You can do it. But, yeah.
That is excellent. So let's get into what is the future or innovative management interventions that are in the horizon for atopic dermatitis? And what is some of your most promising kind of research that's out that you're excited about?
Well, there's going to be probably a slew of more biologics, just the same way it happened with psoriasis. Psoriasis, they came out with one or two, and now there's like one. There's so many. So, there's got to be 20 at this point because there's so many different companies that come at it from a different point of view, a different perspective, or a different target. I mean, just a few years ago, there was no oral or injectable for atopic derm, but now there are 5 different ways that you can approach it. So I'm pretty sure that there's going to be more biologics, more orals, less harmful topicals that you can use that are just going to bring down the inflammatory cascade.
Now, we're hearing a lot in the news about JAK inhibitors. Is that all what it's made up to be, or are there other, exciting potential therapeutic interventions?
JAK inhibitors have come up. And it's because they're to be honest, they don't have to target anything in particular. They just have to take out a cascade. But the serious side, the possibility, the risk of side effects is the problem with JAK inhibitors. I mean, they're coming out for hair loss. They're coming out for psoriasis. They have so many uses now. So you're wondering, are they more specific for the use that I have? But so far, so good. But that is the biggest thing on the horizon that's here to stay for a while.
And with now, comorbidities can range from someone having mild high blood pressure to someone having severe heart failure. What are some comorbidities that you would have a pause or hesitation in starting some of the like the JAK inhibitors on?
So blood clotting is one of the main things that I'm not sure if I said, but the tendency to form blood clots is one of the biggest things for JAK inhibitors. Oh yeah. So we're talking about, I'm thinking over age of 50, obesity, are you on hormone replacement, history of smoking, or history of blood clots in your family? And I'm always surprised at how many people go, yeah, my mom had blood clots. And I'm like, wow, y'all say that. So, or short and like, yeah, it doesn't everybody. And I'm like, no, it isn't. So when I see that lineup, I'm like, okay, I wouldn't put you on that drug.
Okay. So how about insurance coverages for some of the more systemic therapies? Is it, you can cover like you can go, let's say commercial, Medicare, Medicaid?
So commercial insurances will give you a better shot of getting coverage. You have to have a dedicated staff member to get through prior authorizations. And if you can, it's great, but they always want a failure of another drug. It's always a step therapy. But once you do, there are programs that are given by the company that help to pay for those medications, which I think is actually good. Medicare is hard. There's only a few medications that have on Medicare B or Medicare D. Those are harder, and Medicaid is extremely hard to get coverage. Yeah, that one's an impossibility. But if you can get commercial insurance, then yeah. But there are indigent programs where people do not have money that they will actually pay for the whole medication for like a year or two.
Nice.
Or get samples from the drug company, and I've given them to patients as well.